the final episode of the IGCS Education podcast on malignant bowel obstruction in gynecologic cancer. Once again, I'm Peter Grant, co-chair of the IGCS Palliative Care Education Workgroup. And Anisa Mburu, my co-chair and co-moderator, is here with me again. Nisi, can you believe it? We made it to the final episode.
I'm still wrapping my head around that. But it's been amazing couple of episodes. We've learned quite a lot, and I'm excited to what we have ahead.
Yeah. Well, let's get started, and I'd like to welcome our guest speaker, Dr. Michael Pearl. Dr. Pearl, thank you for joining us. Could you introduce yourself?
Sure. It's a pleasure to be here. Within IGCS, at one point I was also a co-chair of the Palliative Care Group, and I'm currently the vice chair of the Education Committee. I'm a practicing gynecologic oncologist and palliative care specialist. I recently moved from New York to New Hampshire.
Well, thank you, Dr. Pearl. In today's episode, Dr. Pearl will chat with us on some future directions and any ideas on research, but he'll also discuss team planning, what happens if there is symptom resolution or no resolution, how to support patients, caregivers, and how we can continue to improve our care. So my first question to you, Dr. Pearl, is who should we involve in the medical team in the care of this patient?
Right. So I think rather than view who we should involve at the end of life, at the end of the patient's pathway, we should consider who should be involved all the way along. So the people who are most important from the patient's perspective, obviously, is the patient themselves, as well as their family or their caregivers. From the medical side of it, this is a multidisciplinary problem. So there should be somebody who is familiar with the surgical management as well as the medical management. And then from the palliative care's perspective, if the primary physicians, primary caregivers within the team are not comfortable, that is the time to bring in a palliative care service. The team that we work with is multidisciplinary. We have pain care specialists. We have a variety of different physicians. We have nurses and advanced practitioners. We bring in whatever the appropriate spiritual support, if that's important to the patient. And then, as always, at least here in the United States, we have access to medical legal advice. And then we include, we have an active pharmacist who's part of the team and a social worker to help us navigate the very complicated medical system that we have in the US, and I'm sure is the same in other countries.
This medical team, can it be structured to not only look after the care of patients, but facilitate education of patients, carers, local health workers in the recognition and initial assessment and aspects of care of malignant bowel obstruction?
Yes, certainly. We do so in a variety of different ways. I work in an academic medical center. I worked at a very academic medical center. We had learners at all levels that were active members of the team. So we had medical students, we had students from the School of Social Welfare, we had nursing students and advanced practitioner students. We go out into the medical community to provide education through grand rounds and lectures within various departments. And then we also go out into the community at large and provide educational activity. For example, we would go to one of the local libraries and give some educational opportunities through them. We hosted webinars and podcasts. We had a community service. It's called a community medical school, where the university supported an educational activity that members of the community could come and listen to a presentation by an expert on a variety of different topics. And on occasion, we had access to providing education material through that route as well.
sometimes in these patients, we do see symptom resolution. And one of the things that is difficult in my experience is knowing, well, how do we wean support from these patients? Is there any particular order? How quickly do we do it? Any thoughts on this?
Yeah, that's a lovely experience when that happens. Unfortunately, it is not all that common of an experience, but on occasion, the symptoms do resolve. The very first thing for everybody to understand, especially the patient and their caregiver, is that with malignant bowel obstruction, especially when it is, for example, associated with recurrent cancer of the ovary, it is rare for the symptoms to resolve permanently. So oftentimes there is a short resolution. It may be weeks, it may be a few months before the symptoms recur. In somebody who presents with a malignant bowel obstruction as their first presenting symptom, that's an entirely different scenario, and I think is probably worth a podcast in and of itself. So if we're going to talk about MBO in somebody with recurrent disease who is fortunate enough to have resolution of their symptoms, we tend to back off on their supportive care, individualized. So for some patients, their primary symptom, the symptom that bothers them the most, and remember, what we're focusing on is relief of suffering for the patients. And so what symptom bothers them the most? Is it their pain? Is it the fact that they're unable to eat? Is it nausea, vomiting? So the first thing is to figure out what symptom is bothering the most. And then if those symptoms start to resolve, then start to remove the support in that order. So if somebody's primary symptom is nausea and vomiting, but they also had pain, and now their symptoms are starting to resolve, I would work on relieving, taking away, or backing off on their pain medication while actively working on controlling their nausea and vomiting, and slowly and steadily work towards relieving or removing that supportive care. Remember, many of these patients, one of the big topics in managing MBO is hydration or nutritional support. We try, if somebody is doing well, we try to wean them back onto oral intake as quickly as possible. That generally is the first thing that's on our list, is to get rid of non-oral intake.
So I think in many situations we're faced with symptoms not resolving, but they've been given active support for some length of time. So how do we wean active intervention supports?
Yeah, that's a very, very complicated question. The issue is, how do we continue to provide support in a way that relieves suffering, but does not prolong the suffering, in essence? So, as is true with many other issues, in fact, most issues, if not all issues in medicine, the first focus is trying to understand what the patient's goals might be. Do they, again, are they having pain? How do we control their pain? Are they having intractable nausea and vomiting? Are they focused on being able to obtain nutritional support? And so when we're confronted with these patients, which unfortunately is the norm, malignant bowel obstruction in many circumstances is a pre-terminal event. So when we're confronted with these patients, I try very hard to continue the goals of care conversation that we've had with them along the entire course, involving the family and the other caregivers, as well as the other members of the medical team, because they're an important component as well. Using the goals of care discussion, we then start to, we then continue the conversation with, excuse me, a very frank, open discussion about what happens if we, for example, stop nutritional support if nutritional support had been started. What are the expectations? What happens if we, withdraw any of medications? What happens if we change and stop their antihypertensive medications or an anti-hyperglycemic medication? So the short answer, I think, to your question is it's incumbent upon us as a medical team to involve the patient and her caregivers into those conversations and use those conversations to guide our management as we start to wean off. First off, and let me say this, there isn't much, if you think about it, there isn't a lot to wean off. And the big thing to consider weaning off, I guess, if we're going to talk about it that way, is the conversation about discontinuing cancer-directed care.
Yeah.
Otherwise, what are we going to wean off? The only truly the only other major thing to wean off, if it had even been started, and we don't generally start it, is nutritional support or hydration. Everything else you're going to continue because it's symptom relief.
Good.
So,
Nisi,
terrible. Michael, what I wanted to know is in some situations we have a scenario where the family insists that you don't tell the patient that you're sort of weaning off care or withdrawing care or weaning off care.
Mhm.
In those types of family scenarios, do you agree with the family not to tell the patient? Because in their mind, they're saying the person will give up hope. So how do you address the situation and make sure that the goals of care are understood by both the patient and the family?
Yeah, that too is an extraordinarily difficult scenario to face. I am speaking from a U.S. perspective. The general belief is that patient autonomy comes first, and it's our responsibility to inform the patients. However, that is, I think, a little bit of a narrow-minded view. Actually, it's quite a narrow-minded view. Patient autonomy includes the opportunity to not know something, and it is incumbent upon us to be respectful in that circumstance as well. So it's not an infrequent scenario. We have a very large, very heterogeneous population, and it comes up on occasion. Generally, again, and it seems to be a recurrent theme in these conversations, it's about the conversation. And the way I approach this is very bluntly, I ask the patient what she wants to know. What is your preference? Do you want me to be fully open and try to communicate everything that I know about your particular circumstance? Or is there an approach that is more appropriate for you and for your family? In some cultures, the senior son is the primary person. It may be the husband or the partner. It may be somebody else that the patient has chosen to be their representative. So I feel very strongly that it is incumbent upon us to determine who the appropriate person is, what the amount of information requested might be, and then to be respectful of those wishes and those decisions. Ultimately, what I would prefer is to make sure that everybody who needs to be informed is as fully informed as possible. If the patient does not wish to know that information, I'm respectful of that request.
Good. Michael, one of the things that I find interesting is trying to figure out how well we did. And have you got any tips on how we get appropriate or feedback from the patient's family, carers about what was done well, when we get that feedback, and how we can improve?
And I think that's a very important part of the process. It serves a couple of goals, right? One is obviously to help the team improve the quality of care that they're providing. The second, from a team approach, is that it provides some closure on caring for the patients. It's far too easy when a patient passes away to just quickly move on to the next patient. We're all extremely busy. It seems like there's always more people that need our help coming down, into our practices. And so the the tendency is to just say, okay, that's done, let's move on. And that's the reality. We're busy. It's hard to say goodbye. And so it's a little easier sometimes to just say, okay, let's move. So in order to combat those tendencies and to help us improve the quality of care that we provide, we try very hard to do a formal review, in essence. So we have an organized session where we talk as a team. One of the questions exactly is, what did we do well and what did we not do well? Meaning, what can we do better the next time? And then if there were issues that arose during the care of an individual patient, there was a conflict with the family, the patient had a particular problem that was difficult to help manage. If there was a legal issue, if there was a religious, spiritual issue, then we focus on trying to address those issues as well. One of the things that I've done personally, I don't think my GYN oncology partners have done this, but for me, I found that it really helps. At the end, I work very hard first to say goodbye. So if I'm seeing a patient and I know that that's the last time I'm going to see the patient, I acknowledge that fact explicitly. Thank you for letting me take care of you. I don't expect that we'll be seeing each other anymore. And I say goodbye. The other thing that I do is with the family is I tell them explicitly that if they wish to have a time where they come in and talk to me and or the team after their person passes away, that we will book a time for them to do that. That's free of charge. There's no bill to an insurance company. And I try to book an hour so that if they want to come in and sit down and have a conversation, that I'm happy to do that. And I think that more than the actual, most people don't take me up on that opportunity. There's been a few here and there, but I think for them, just knowing that I'm available and the team is available and they're willing to talk to them, I think that helps tremendously. There's only been a few over time that have come and done it. I found that very rewarding. It's a very cheerful circumstance, but it is extraordinarily rewarding.
Right. I've got one more question, unless Nisi has something, but have you any suggestions about managing team fatigue and emotional distress in dealing with this over time?
Yeah, that too is a very good question, and something that as time has gone on, I think we're starting to pay more attention to the fact that that we're important as well. You know, that we're not robots, we're not automatons, that we have feelings, emotions, and those feelings and emotions are important to acknowledge. So, at least in my old institution where I was actively working on palliative care, we had regular sessions where we would decompress, in essence. We would talk about things that were stressful, and kind of back to what did we do well, what didn't we do well. I think if there's an underlying theme in this whole conversation is conversation. It's all about communication. So we've made it very clear amongst the team that it is okay, it is expected to speak up and say, look, I'm struggling, I'm having problems, I'm feeling particularly stressed about this particular patient for whatever reason that might be. And it's non-judgmental, that we are all human and we do have emotions, and this portion of practice is emotionally very difficult and very draining. So we try very hard to be available to each other. The institution had a wonderful thing called Code Lavender, and I actually saw it used once. So like Code Blue or any of the other codes that might be out there, Code Lavender is for staff support. Somebody could call a Code Lavender and say, I need help. And so one day I was coming, one night actually, I was walking across the corridor and there was a young nurse in this little tiny corner sobbing uncontrollably. And she was just overwhelmingly stressed. So we called a Code Lavender, a team showed up, and it was really quite remarkable. So we communicate.
We've got time for one last question from Nisi, if that's all right.
Yes, I love the idea of the code lavender. I think we all need to have a sense or somewhere where we can actually vent.
And
So my question would be, how do you deal with team conflict? For example, if a patient, maybe the surgeon, for example, would like to take a patient in for surgery, and you as the GYN oncologist or palliative care specialist think that surgery is not the best option, how do you resolve such team conflicts?
right, that too is an excellent question. It comes up on occasion. Again, you know, here's the theme throughout this whole discussion is that it's about communication. So we try very hard to be respectful of each other's views on the team. It doesn't mean that we always agree with each other, and it doesn't mean that people don't express those views in a forceful way. But we do try to be very respectful. On occasion, it feels like a showdown, you know, like an old-fashioned Western movie. But at the basis, there is a sense of mutual respect within the team. So if there is a serious conflict, somebody thinks that the patient should go to the OR, somebody else does not think that the patient should go to the OR, we have a conversation as a team. Each member is expected to present their viewpoint, their perspective, and the reasons why they might have a management that would be their management decision. And then we go around and try to make a decision. Somebody always wins, I guess, and somebody always loses those conversations, because you can't compromise and say, okay, we're going to do a little bit of surgery if we're going to use that one as an example. And ultimately, what we try hard is to make sure that we've explored all the possibilities, that we understand the reasons why somebody might be recommending a particular course of action, and then at the end, we try to circle back. So if the decision is to take the patient to the OR, and the patient goes to the OR and the outcome is poor, we try to understand where we might have done better. If the outcome is excellent, then we try to understand why that worked so well, so that the next time the circumstance shows up, we have a little bit better understanding. But the core of all of this, the true core of all of this, is communication, communication, communication. It is open, honest communication that is respectful of each member of the team, obviously respectful of the patient and respectful of the caregivers and the family. It is all about communicating and communicating well.
Thank you. I think
You
we've
did.
run over time already, Michael. There's
Yep.
enough in this that we could do another podcast. Thank you very much, Dr. Pearl, for taking time to join us today. I hope the listeners feel the same. Nisi, have you got anything more to say?
I agree, Dr. Grant. I think we can literally keep on going if we don't stop at this point.
Yeah,
We can.
Well, as we conclude this podcast, I was hoping we could summarize some of the key points from the earlier episodes, but we've probably run over time, and I want to encourage people to listen to all the episodes because there've been some fantastic conversations with our expert speakers. And this podcast series was a success due to them sharing all their knowledge and expertise with us. We hope you found it of benefit, and we encourage you to take what you've learned back to your patients to improve the care that we can give our patients. Thank you all for listening, and you never know, we might even do some more sometime. Thank you.